It is indeed an honor to speak in this symposium on this very important issue of aging in people living with HIV. So in the next 30 minutes, we'll first look at some recent data studying biological aging processes in people living with HIV. This will set the scene for the next part of the talk, which will focus on how the aging processes will be expressed clinically in our patients. And lastly, we will see how our understanding of aging should impact our clinical management. A lot of studies looking at biological aging processes in our patients attempted to answer a very important question. Do people living with HIV age at a more rapid pace than the general population? So what is aging? Well, as one ages, a lot of changes occur in our body, from the intracellular to cellular levels to different organs and organ systems. What is intriguing is that for different people at the same chronological age, they age at a different pace in terms of these biological processes for various reasons. And over time, there are a few hallmarks of aging that are discovered to reflect this biological process of aging. These hallmarks are able to predict and monitor the aging process and predict clinical outcomes. And importantly, they are good targets for potential therapeutics that can slow down or even reverse the process of aging. And in people with HIV, a lot of these hallmarks of aging has been studied. For example, the shortening of telomere, the end of the chromosomes, epigenetic changes such as DNA methylation alterations. Thank you. Mitochondrial dysfunction, as well as cellular senescence, especially in the immune system. Patients with HIV are well known to be having a chronic pro-inflammatory status, which are due to a lot of the other processes, including dysbiosis of the intestinal gut flora, as well as senescence, etc. So from these studies, what we have learned about aging in people with HIV. It is quite likely that the aging impact occurs very early after seroconversion. In this study, around 30 intravenous drug users were followed from before the time of infection to around 2 to 4 years after seroconversion. They measured the telomere length as well as the DNA methylation, reflecting the epigenetic age acceleration. So you can see on the left that in the first 2 years after seroconversion, there was a significant shortening of telomere length. And also, the epigenetic age lengthens with time from the diagnosis, and this lengthening occurs soon after seroconversion. And in people who haven't yet started on antiretroviral therapy, but with a relative preserved CD4 count, for example, in this cohort of participants from the START trial, it has been shown that the DNA methylation patterns differed from people without HIV infection. And also the epigenetic age acceleration was also higher. And a very important question is whether the use of antiretroviral therapy have any impact on aging. And luckily, the answer is yes. These two studies shown here are sub-studies of a randomized trial randomizing naive patients to 2 different antiretroviral therapy regimens. These patients are followed up at baseline and 2 years after treatment, looking at their telomere length and epigenetic age using different epigenetic age clocks. And you can see that at around 2 years after treatment, there is a lengthening of telomere length. And with the epigenetic age clocks, there's also a reduction in the epigenetic age. However, at 2 years, the age is generally still higher than the matched HIV-negative controls. The timing of initiation of antiretroviral therapy also plays a role. This study from the Swiss HIV cohort very nicely followed around 100 patients with known time of primary infection with different timing of initiation of antiretroviral therapy as shown on the left. and they are followed up to more than 5 years after initiation of therapy. And you can see that even with a delay of a matter of weeks in terms of the initiation of ART, there is still an impact on aging in the early stage and as well as on long-term follow-up. And in terms of immune senescence, a lot of studies have been done in people with HIV receiving antiretroviral therapy. In general, there is a higher degree of activated T cells and monocyte activation, and there's also evidence of increased inflammation, for example, increase in counter-regulatory pathways such as the Tregs, and also increased expression of PD-1 cells. And these T cell activation is also related to T cell senescence. So what does all this data bring us up to this point? There was a very good review article published earlier this year in eBiomedicine, and this diagram here summarizes what we currently believe about aging in people with HIV. The blue line shows the aging processes in the general population. So the biological aging would be fairly similar to what's predicted by the chronological age. In people with HIV, it's quite likely that soon after seroconversion, the aging processes is heightened. And with the initiation of antiretroviral therapy, the trajectory is brought more closer to the general population. How close this is from the general population would depend on a lot of factors, including the timing of initiation of antiretroviral therapy, as well as other host factors. And why do people on antiretroviral therapy still have a heightened pace of aging? That's, of course, due to a lot of different factors. People who present late might have a lot of complications at the beginning, infections, cancers, and associated treatment, which would have some impairment to their tissues and organs. A chronic degree of inflammation, T cell activation, the persistence of HIV reservoirs, these would also contribute to these aging processes. And of course, the use of drugs, either for HIV and also for comorbidities, might also have impact on the different tissue and organ functions. So how do patients actually present with this aging issue? So several studies have looked at correlation between these hallmarks of aging and clinical events, and here are a few examples. Again, from the Swiss HIV cohort on the left, they looked at around 300 people with known cardiovascular diseases and matched to around 700 controls. And they measured the telomere length, and you can see from the topmost rows, those with the longest telomere length, i.e. with the youngest biological age, did have a reduced risk of coronary artery events. And on the right, another study looking at the epigenetic age, those who did have some clinical events, including AIDS and non-AIDS serious events, also had a higher epigenetic age. This study looked at the telomere length in people either having HIV infection, methamphetamine use, or both conditions, and telomere length is independently associated with either of these conditions. And more importantly, they look at the association with other parameters reflecting general health. So telomere length is shown to be nicely correlating with markers of inflammation, endothelial activation, the risk of cardiovascular risk, stroke, axonal injury, etc. Another very recent publication by Dr. Han's group performed here in Thailand showed that the use of PhenoAge, which is a marker combining different clinical variables that have been shown to reflect biological age, very nicely correlated with the presence of pre-frailty and frailty. And importantly, PhenoAge predicted frailty better than chronological age in people with HIV. Currently, very sophisticated imaging techniques in the brain also allow us to look at biological aging inside the brain. So these studies using MRI measuring the brain volume in different anatomical sites and also some microstructural changes in the white matter, which also reflect brain aging, also show that comparing with HIV-negative controls, people with HIV in general have a greater decline in brain volume and also this a greater gap in terms of the brain age. Quite a number of studies have been performed in various countries comparing the number of age-related comorbidities in different age groups between HIV positive and negative controls. Age-related comorbidities include things like hypertension, cerebrovascular disease, cardiovascular disease, chronic kidney disease, in which we do expect a higher prevalence and incidence in people who are older. And all of these studies basically show that the number of comorbidities in people with HIV are similar to the number of comorbidities in the general population who are in general 5 to 10 years older. So what does this mean? So it's very likely that people with HIV have a much earlier onset of these age-related comorbidities. An example shown here, a study performed in China looking at subclinical atherosclerosis. In the older age group on the right side, age about 60, there was not much difference in terms of prevalence of subclinical atherosclerosis. However, in the younger age group, especially in the very young age group, 18 to 30 years old, there was a significantly higher prevalence of atherosclerosis compared to negative controls. So this early onset does have impact in terms of long-term impact for our patients. Another study from UK showed very similarly in cardiovascular diseases and hypertension, the age of onset was also significantly younger in people with HIV. So many of us are quite familiar with these non-communicable comorbidities because of the very well-known increased prevalence in people with HIV. But as HIV-ID clinicians, I believe many of us are less familiar with these geriatric syndromes, which are, of course, very important in people with HIV, since we are talking on the aging trajectory in our patients. So geriatric syndromes are a constellation of syndromic presentation that is not due to a single disease entity, but rather due to multiple factors, but independently predict poor health outcomes in the long run. So the list here on the right show some of the examples like frailty, multimorbidity, polypharmacy, disability, cognitive impairment. So this study was performed by Dr. Adiba's group in Malaysia, and they compared people with HIV and age and sex-matched controls. And there are a few geriatric syndromes like polypharmacy, multimorbidity, cognitive impairment that has much higher prevalence in people with HIV. And more importantly, these presence of geriatric syndromes also correlate with increased utilization of healthcare services and also a reduction of quality of life in these patients. So here are a few of these examples of geriatric syndromes. So we have heard yesterday from Dr. Gail Matthews that in long COVID, these different symptoms comes in clusters. And the same is true for multimorbidity in people with HIV. So you can see that different types of comorbidities come together in different distinct clusters, meaning that patients with a single disease within that cluster would have a higher chance of having other diseases within the same cluster. Another example showing the interrelatedness of these different comorbidities, how they interact. This study from the Charter study looked at neurocognitive decline over a period of 12 years. And cognitive decline was not very much associated with HIV-associated factors, but rather is associated with a different constellation of comorbidities, both at baseline and at 12 years. Polypharmacy is another very related concept, example of geriatric syndrome. In most studies, polypharmacy was defined as the use of 5 or more drugs, usually excluding antiretroviral drugs in people with HIV. And these 2 studies are from the HIV Women Interagency studies, and they've shown that polypharmacy independently is associated with neurocognitive decline, poorer performance, and also increased risk of falls. And the highest risk of drugs categories include those which are known to have neurocognitive side effects and also drugs with anticholinergic activity. So frailty, of course, is one of the most important geriatric syndromes. It is defined as a state of increased vulnerability to adverse health outcomes in response to a wide variety of stresses. And again, is independently predicting the development of new comorbidities, disability, hospitalization, and death. There are different definitions of frailty or diagnostic tools in the clinic. The most classical definition is using the Fried phenotype, and it comprises of 5 items: unintentional weight loss, exhaustion, a slow gait speed, a weak grip strength, and also low level of physical activity. There are also other tools that serve the purpose of screening for frailty. For example, the Frail scale shown here on the right, which only consists of 5 simple questions that can be easily implemented in the clinic setting. And among all these different categories within the frailty phenotype, it has been studied that in people with HIV, in particular, the grip strength and gait speed are usually more impaired when compared to HIV-negative controls. And interestingly, frailty is actually a dynamic state, which means that patients can transit from one to another state over time. So this is from the Netherlands Amsterdam aging cohort. They compared around 500 HIV positive and matched negative controls followed for 2 years. So at baseline, it is not surprising that people with HIV, as shown by the blue bars here, have a higher prevalence of pre-frailty and frailty. And also over a period of 2 years, for those in the initial robust status, more HIV-positive patients progress to pre-frailty. But what's interesting is that for those who have frailty at baseline, indeed, more HIV-positive patients actually revert back to the pre-frailty and robust status. So this is actually very good news for our patients, meaning that this is a reversible condition, and potentially there are interventions that can be implemented to expedite this reversal or even prevention of frailty in at-risk population groups. A very related topic is the issue of sarcopenia. There are well-established guidelines, especially from European and Asian consensus group, defining what's sarcopenia. So it's not just a loss of muscle mass, but we also have to measure the muscle function. And it's usually represented by the muscle strength, which is usually measured by the hand grip strength, as well as physical performance. And there are different parameters to measure physical performance. A very easily performed one in the clinic is to measure the normal gait speed over a distance of 6 meters. In our clinic, we have evaluated the prevalence of sarcopenia in our patients followed up in our clinic, around 150 of them, the mean age 60 years old. And not surprisingly, the prevalence of sarcopenia and severe sarcopenia was very high. 27% of them had sarcopenia using the revised definition, and 18% of them had severe sarcopenia. And what's very important is that the presence of sarcopenia actually translates to poor health outcomes. So compared to people without sarcopenia, patients with sarcopenia or severe sarcopenia have higher prevalence of problem with mobility, usual activities, and impairment in instrumental activities of daily living. And I guess the issue of double stigma associated with HIV and aging should not be neglected. So various studies have shown that the reduction in quality of life secondary to physical and mental comorbidities related to age would make our patients more vulnerable to stigma and also the impact associated with stigma. And the subgroup of people who already have poor social family support and poor resilience would be the ones who are most affected. And disclosure issue is actually something that our aging patients might have to encounter again. Some of my patients have been keeping the HIV status from their family for a long time. But when they are getting older with other health issues, it's very likely that they will be dependent very soon. And again, at this juncture, the issue of whether disclosing the HIV status becomes a very practical issue for them. However, these studies are not all negative. There are actually some positive side to aging patients. So some studies show that the older people with HIV compared to the younger patients actually had better mental health, and in some realms such as spirituality, they score higher. And this is actually not too surprising since they have been having a chronic disease for so long. Over time, they must have developed some adaptive coping strategies and developed some positive attitudes. And I believe this is something we should highlight to our patients as they might have to face other new issues because of aging. And this brings us to the last part. So is aging well possible for our patients? Well, the use of early antiretroviral therapy obviously would play a key role in the issue of aging. So as shown in the earlier data on the aging studies and also large trials like the START trial, earlier diagnosis, earlier initiation of antiretroviral therapy would reduce the risk of both AIDS and non-AIDS events in the long run. And I guess the whole paradigm of managing HIV clinics should really not just focus on the discussion of antiretroviral therapy, monitoring CD4 count or viral load. This is a picture taken from the European guidelines, which I'm sure all of you have read. So this is a picture of the contents page. And the topics highlighted in orange is from the part on comorbidities. So you can see the volume of space attributed to the management of comorbidities in people with HIV. So I believe this is really a very integral part of our management in HIV clinics now. And in the last 2 days, we have talked about a lot about prevention, early diagnosis, tuberculosis. Today, we've talked about cancer screening yesterday. And I'm sure different settings have different protocols in terms of screening, early identification. And on this slide, I think the most important is start early. So we have seen that these age-related comorbidities really have an earlier onset in people with HIV. So we don't wait until our patients get really old in the normal sense before we start these screening. A problem regarding screening of comorbidities in people with HIV is that there are some challenges in what is the right tool to use. So this is one of the examples. So I guess many of our clinics, when we estimate the cardiovascular risk, we use existing risk scores like the Framingham score, like the Q-risk score, etc., etc. However, many of these scores, firstly, are not developed in the Asia-Pacific population, and secondly, are not focused on people with HIV. So how accurate is the performance of the tools in our own population is actually quite uncertain. So this is one of the studies our group has done previously. We looked at the analysis of retinal images and correlated with the presence of coronary artery disease as diagnosed by CT scans. And we've shown that incorporating retinal information together with the traditional risk factors have a better prediction of coronary artery disease, especially obstructive coronary artery disease. And as I've mentioned, as an IDHIV physician, I guess many of us are not very familiar with these geriatric syndromes, not to say the monitoring and actually implementation of the screening process. So these are some of the examples of the screening I have been doing for my patients annually or biannually in the last couple of years. I must say we did receive some training from our geriatricians, from our neurologists when we first start the screening program. It's not something that's very hard to learn, but after some training for our staff, in fact, we were able to provide these screening for our patients. And of course, the choice of the tools really depend on our setting and our resources available. So as mentioned, for example, for frailty, in some of the studies, the hand grip strength and the gaze speed might be more sensitive tools in detecting frailty. So the choice or the selection of the tools can be chosen from the existing data. And one of the benefits for screening from my experience is that, of course, it allows earlier detection, diagnosis of problems and initiating early intervention. But on the patient part, actually, it enables them to understand their own health, and also is easier to make them accountable for their own health. I have been discussing weight issues with a lot of my patients, and sometimes they are not too interested. For people who are older, not too concerned about their body image, they are not really concerned about body weight control. However, there are patients, when we do fibroscan, and they are informed that they are actually having quite severe fatty liver. Several of these patients would suddenly realize that body weight is not just associated with body image, but did have a very true impact on their own health. And that's actually an opportunity for us to have more discussion on various lifestyle intervention, as Dr. Sobat has earlier referred to. And for management of geriatric conditions is really a challenge for many HIV-ID physicians, I guess. In Hong Kong, we do have quite good resources in the community for people who are aging in the community, providing educational materials on various geriatric syndromes. I'm sure in different countries there are similar easily available resources. And these are actually very good tools we can use for our own patients as well. And lastly, in terms of the healthcare system, healthcare structure, there are a lot of debate what's the best model in providing comorbidities and also geriatric care to people with HIV. And I guess in different settings, there's no right or wrong answers, but different settings would have to see which kind of model suits their setting best. And but at the end of the day, I believe that, as mentioned, the incorporation of screening, management of comorbidities, as well as these geriatric conditions, should be an integral part of our care to people with HIV. And what we have to learn, I guess, is to switch our mindset to become more like a geriatrician, as we are aging ourselves with our patients. So not really just focusing on the treatment, on the viral load suppression, on adherence, but also on the other aspects, what's truly impacting our patients' quality of life. So that's probably is one of the most important aspects in our clinic management. So ladies and gentlemen, we believe that accelerated or accentuated aging is observed in our patients and partially refers by early use of antiretroviral therapy. Earlier onset of comorbidities and higher prevalence of geriatric conditions do affect the health outcomes. Therefore, screening of comorbidities and these geriatric conditions should be an integral part of integrated and person-centered care for for our patients. So thank you very much.